So we break this up into 4 different sections. Basically, we're going to have the first section being mostly on hyperlipidemia. Why do we care about hyperlipidemia with cardiovascular systems? Yes, because we're going to find that this has such a huge effect downstream, right, over the course of decades on a patient as far as developing that cardiovascular risk, right? So before you need a lot of these other medications, guess what? You probably had hyperlipidemia first that we need to deal with, okay? We'll move into the hypertension medications. You're going to find a lot of those meds are going to carry over into a lot of the other things we talk about, right? So the same meds we use for CHF are a lot of the same ones we use for hypertension, okay? And then we'll talk a lot about antiarrhythmics, talk about angina, acute coronary syndrome, all those sorts of things, okay? So those are kind of the big topics we're going to be hitting on as we go through these different sections here. So first off, let's look at the lipid-lowering agents here. Where do we get our fats from that are circulating in the bloodstream? Food, right? So we have dietary sources. What else? Yeah, we can produce it ourselves, right? So, some people have more stores than others. I've been trying to work on some of my stores, right? But it's one of those things where we have adipose tissue, right? We can generate that cholesterol, those triglycerides and things like that we need in our bloodstream, right? What do we use cholesterol and triglycerides for? To make cells. Cell membranes, yeah, absolutely. What else? Hormones, yeah, hormones are super important. It's funny, like when people, when they want to go on a diet, they're like, oh, I'm cutting out all fats. You can't do that. Like, you need fats. You got to be able to produce things like hormones and to make cells. Like, you got to have, one of these balanced diets. But this is one of the big things to note here. So, we can't get rid of all cholesterol because we need some of that. But what's the problem of having too much? It's going to deposit into, because again, it's got to go somewhere. So, right, if you don't have enough adipose tissue to shuttle it into, it's going to start to go into the endothelial lining. What happens there? Inflammation. It's going to get thicker. It's going to get more likely to have a rupture at some point as you occlude those vessels more. Something breaks off. Guess what? And all of a sudden you can have an embolus that forms, right? That happens in the coronary vessel. Guess what? Now you got an MI occurring here. So this is why it's so important. And one of the big things we're going to find here is that not only do we want to try to prevent that atherosclerosis from occurring in the first place, it'd be nice if we could, but a lot of patients you can't. We want to prevent it from getting any worse. And if we can stabilize those plaques, right, those atherosclerotic plaques, that's going to be a really good thing. So that's why a lot of the shift has gone not just from treating a number and saying we want your LDL to be this number. It's more that we want to be on this intensity of drug because we know that this is going to stabilize those plaques and hopefully prevent anything from breaking off or anything from getting any worse as time goes on. Okay, so the mantras change a little bit, and depending on who you're talking to, older providers maybe you're still looking for, let's get the LDL less than 70, let's get the triglycerides under this number, but it's not really the thing we're going to be focusing on quite as much going forward, as you'll see. So anyway, again, we get some amount of triglycerides and cholesterol from our diet. Obviously, it's going to be very variable depending on what your diet's like and who you're talking to. One of the big things you're going to see is that as we ingest these cholesterols, what happens? How do we break them down for absorption? What comes out of the liver? How do we? Yeah, the bile, right? The bile salts are going to be good at emulsifying a lot of these lipids and breaking them down into smaller components, right? You have to break down all of the macronutrients into smaller pieces so that you can actually absorb them effectively, right? You can't just absorb a whole hamburger. You're going to break it down into individual amino acids. Same thing for fats as well, right? So this is where the bile salts are going to be important here. Remember, the bile salts are also made up of cholesterol, so this is going to be an important mechanism for trying to get rid of some of that a little bit later on when we're looking at our different mechanisms of actions of our different drug classes. So kind of keep that in the back. Basically, you're going to be finding that some dietary cholesterol is going to be coming in through our diet. You have biliary cholesterol as well in the form of the bile salts. That's going to start to emulsify and get these down into smaller and smaller components here, right? Once you get this kind of micellar cholesterol, this is where it's going to start to be absorbed. You're going to have what we call these chylomicrons, right? Chylomicron sounds like a Star Wars, like a villain, perhaps. But chylomicron is basically going to be a mixture of fatty acids, some triglycerides, and cholesterol, basically. And we're going to see kind of how these components will shift as time goes on. What you're going to find is that things get absorbed through the GI tract. Where do they go to first? The liver. All right, so they're going to be hitting the liver first. And so what you're going to find is these chylomicrons have a very high amount of triglycerides, right, with a small amount of cholesterol that we're going to be absorbing here, okay? What you're going to find is that you're going to have metabolism of these substances as you deliver some of the triglycerides or cholesterol to the cells for their eventual uses. As you start to have this metabolism, you're going to find that it will start to kind of morph and change into various molecules. And we're going to see how we talk about these when you look at your lipid panel. So chylomicrons are going to hit the liver. Within the liver is where we're going to start to generate things like these very low density lipoproteins, okay? That just means that these are these kind of molecules, I'll show you a picture in a second, a mixture of triglycerides and cholesterol, and they're going to have these proteins that act as kind of the receptors, right? They're going to be interacting with the receptors on the cells. Okay, so these proteins are very important there. Notice here, as you get kind of more metabolism occurring, you're losing more triglycerides, and you get down into very high cholesterol ratios here, right? So mostly, by the time you get down to LDL, the low density lipoprotein is mostly just made up of cholesterols. Now, VLDLs is important. That's where a lot of your triglycerides are coming from. So when you measure that on a lipid panel, typically that's what you're kind of referring back to, is like what's the VLDL and the IDL sort of concentration of the blood here. But you're going to find more and more metabolism, and eventually we get down to our LDLs. Now, why do we care about LDLs? That's the bad cholesterol, right? That's the stuff that's going to be causing the plaques that we're so worried about, right? So what you're going to find is that you really have to have these LDL receptors. LDL receptors are located peripherally on the cells. We're going to be uptaking cholesterol. They're also located on the liver. The primary place that your body gets rid of LDL is the liver. It's our main site of metabolism for lots of things like drugs, also for LDL. Okay, so again, if you have more of those receptors, guess what? You're going to take up more of them. You're going to metabolize more of them and get rid of them. That means your blood levels of LDL is going to go down, right? Okay, if we have fewer receptors, LDL concentration is going to go up. So obviously one of the things we're going to focus on as well with drugs is to getting more LDL receptors available. Okay, one of the ways we can do that is by dropping the intrahepatic levels of cholesterol and triglycerides. If the liver's detecting I don't have enough of that around here, it says, well, I got to get it from somewhere. If I'm not getting it from the diet, let's get it from the bloodstream. It's going to upregulate those LDL receptors and then try to uptake more of it from the bloodstream. Okay, it's another big way you're going to see that we're going to focus on getting those cholesterol levels in check. Okay, and then finally you have HDL. What is that? It's our good cholesterol, right? So what is that doing? Yeah, it's going to take up cholesterol from peripheral sources and then eventually bring them back to the liver. That's why we call this the healthy cholesterol. That's why we like that. It has a protective feature from a cardiovascular standpoint. So that's why we normally look as if you have low HDL, it's considered a negative risk factor there. It's something we say, hey, that's no good when we get those levels up there. And we'll find some drugs are actually really good for getting HDL up. So anyway, here's an example of what one of these might look like. Notice here you're going to have sort of a nice lipid membrane here, just like any other sort of molecule floating around in the bloodstream. These proteins here, what's going to be interacting with those receptors. So you need to have those present and interact with the receptors in the actual cells for them to be taken in, right? And just notice they're going to be kind of floating around, just kind of big balloons full of cholesterols and triglycerides. And that ratio shifts as you get down to more like LDL and HDL and whatnot. So anywho, looking at the LDL receptor action, you can imagine this is one of the hepatocytes. You're going to see that this will then bind to one of these receptors. It'll get taken into the cell itself. It's then going to break down. It's going to have your amino acids. There's some cholesterol there, all those sorts of things. And then eventually you want to recycle that receptor. So it's going to get transported back up to the cell surface where it can then interact with a new molecule of cholesterol, right? And again, the more receptors you have available, the more LDL we're going to be able to take up out of the bloodstream. So looking at our different drugs, we're going to have different categories here, so different mechanisms, different ways to skin the same cat, essentially. So one of the big ones we're going to focus on is going to be the statins. Okay, statins are going to be our gold standard for hyperlipidemia management. Okay, we're going to also have drugs that are going to be things like bile acid sequestrants. We're going to have cholesterol absorption inhibitors. We're going to go over all of these, but you can reference back to this and kind of see where these drugs are going to be working at individually. Okay. So here's a list of the different drugs we're going to be covering. So again, the HMG-CoA reductase inhibitors, it's kind of a mouthful, we'll just say statins, are going to be our gold standard, but then we'll also see there's a couple other classes here that we're going to be using as well. Okay. So talking about the statins, we'll talk a lot about these because they're so important, not only from a therapeutic standpoint, but also from the fact that there's a lot of drug interactions, there's a lot of dangers associated with these drugs if you use them inappropriately. So we have drugs like lovastatin, simvastatin. Obviously, if you're curious if the drug is a statin or not, what do you look for? Statin in the name. That's one of the easy ones, right? I can't guarantee they're all going to be this easy when you get to different classes, but this is one of the easier ones to remember. So see statin, just know that it's a statin. Anyway, so the big ones you're going to probably see used most frequently, and the ones the guidelines probably put the most stock in, is going to be atorvastatin and rosuvastatin. Those are going to be the two most potent agents we have out there, and I'll show you what those guidelines look like a little bit later on, so you get a feel for that. But just kind of keep in the back of your mind that those are the two kind of the heaviest guns as far as statins go. They're going to have the most potency to get the LDL down. Simvastatin is also another very common one that probably got kind of the most use before things like Crestor came out. You'll still see that on a lot of like cheap drug lists or free drug lists, like if you go like Publix or Walmart or something. So that one still gets a lot of use, but maybe not as potent as the other two. Okay. So anyway, the way these drugs are working, you don't have to memorize this whole pathway, right? But the main thing I want to show you is that this is the way that the liver is able to synthesize cholesterol sort of de novo, right? So if it needs to generate cholesterol, this is where it can start off with acetyl-CoA, which we know acetyl-CoA is really important for things like the Krebs cycle and aerobic metabolism. Hopefully you guys remember that from your biochemistry, right? Anyway, acetyl-CoA is eventually going to get turned eventually into actual cholesterol, right? So if we can interrupt that process, if we can stop the liver from doing that, guess what? We have less cholesterol, we have less LDL, right? So this is where our statins are going to come in. They're blocking the enzyme HMG-CoA reductase. And by doing that, you're interrupting the ability for the hepatocytes to form new LDL. Okay, that's at the bare minimum what you need to know about the way these drugs work. Okay. So essentially looking at the hepatocyte versus the systemic circulation, what you're going to find here is by decreasing cholesterol synthesis, that intracellular cholesterol goes down, obviously. And so this says, well, I got to get cholesterol from somewhere, so that's where you're going to have upregulation of these LDL receptors, okay? So they'll make more receptors, they're going to put them out on the cell surface, and then you start to grab that from the bloodstream, right? It's kind of scavenging that LDL from the blood. By having less cholesterol being made in the hepatocyte, that means you're having less VLDL being made, right? And that's a high triglyceride content sort of containing molecule. So that'll get less of that in the bloodstream, which means eventually you have less of that to turn into LDL as well, which means your blood levels are going to go down. Not only your triglycerides are going to go down, because VLDL is going down, but your LDL is going down as well, okay? Those are the big things you're going to be seeing with that. You'll also get some increases in HDL, but this is not really the primary action of the statins. Okay, we'll see some other drugs that are really good at getting HDL up, but this isn't really the best one for that. But they'll still have some positive effects here. So in general, you're going to have lowering of your triglycerides, lowering of your LDLs, total cholesterol, obviously, which is kind of an amalgamation of all those components, are going to go down. HDL should go up a little bit. Okay, we'll talk about the different ways that these drugs are working in kind of a graph a little bit later on. That we'll kind of compare them together. So that's okay. That's great. We like to get our LDL down. We know that's good from an atherosclerotic sort of standpoint, but there's also these other effects that we see, and we know this because we've done huge studies with this. Anyone ever heard of like the Framingham heart study? Yeah. Massive study. You know, tens of thousands of patients. They followed them for decades. You know, those are like the best kind of evidence you have because you can look at huge numbers of people, huge amounts of data for a really long time point to really say, what the heck are these drugs doing? Are they actually decreasing mortality? You know, it's one thing you can't really run a study for 5 years and say, does this decrease mortality? Because guess what? A lot of people live for longer than that 5 years. So because of that, and I guess it depends on the disease state, if it's cancer or something like that, that may be more appropriate. But for cardiovascular cases, you know, these may be decades we're talking about here before you would actually see a difference in mortality. So what we see with statins, what we found out is they have what we call these pleiotropic effects. Pleiotropic is just a fancy way of saying they're kind of ancillary effects that you're going to see that aren't really related directly to the mechanism of the drug, but we still see that they're present, right? They're very helpful effects here. So for instance, we can do things like decrease inflammation. We can help to improve endothelial function. We can stabilize those plaques. By doing all of these things, by having some positive effects on blood pressure, by helping enhancing angiogenesis. What is angiogenesis? Forming new blood vessels, right? It's good because, again, more blood vessels means more blood flow, means more oxygen delivery to places like the heart, right? So this is all really good things. And so we don't really see these effects with a lot of the other classes of drugs, which is why statins have gotten kind of they take the stage, essentially, as far as hyperlipidemia goes, because they have all these really good effects we like, okay? So if you had to, like, you know, look at one set of drugs to like put into the water supply because it'd be kind of good for all of society, like this might be one of them, right? Because of these really positive effects you see from this standpoint. Okay, not that I'm actually saying you should put drugs in the water system. However, you can't measure a lot of drugs in the water system because a lot of it gets flushed down the toilet or things like that, and so you can actually measure detectable drug levels. Anyway. So the key thing I want to know here, don't memorize this whole chart, right? So the differences between the different statins are one going to be their absolute potency, right? So you're going to find that not all statins are created equal. Some of them are going to be much more potent at lowering LDL than others. So we talked about atorvastatin, rosuvastatin being kind of the big guns there. The big thing to know as well is that, you know, things like, you know, the half-life can change depending on which drug you're looking at. But the big thing I want you to focus on is the major metabolism here, okay? So what do you notice about some of these? CYP3A4, interesting, right? You wonder why I keep making such a big point about this. So this is really important because you can kill somebody, right? If you were to have someone on a high-dose statin and it was metabolized through CYP3A4, and all of a sudden I'm going to give you, hey, you got you know, acute bronchitis, I'm going to go ahead and give you a Z-Pack. Z-Pack is azithromycin. What does azithromycin do? Inhibits CYP3A4. All of a sudden those levels of simvastatin are going to go up. Guess what? Now you're going to see some toxicity there, right? And this can be potentially fatal, so you got to be really careful with this. This is another big one where grapefruit juice is going to be affecting the drugs as well, right? And again, older individuals, taste buds start to go out. What do they like to drink? grapefruit juice, right? Because they really stimulate those taste buds there. So this is one of those things where you have to be really, really careful. That's also why we like things like rosuvastatin, because if you look at rosuvastatin here, see minimal CYP enzyme interaction. This is great because you avoid a lot of those problems that you see with that. Okay, so again, the big ones you're going to find that are not CYP mediated: rosuvastatin, things like fluvastatin, which honestly doesn't get clinically used very, very often, things like pitavastatin. So kind of note which ones are going to be 3A4 versus which ones are not, because that's going to help you out as from a drug interaction sort of standpoint.
Is it a CYP3A4 inhibitor or inducer?
So these grapefruit juice?
No,
so these are all substrates of CYP3A4. They're not inhibiting or inducing them. Okay. So again, always keep that in mind. Things can either be a substrate for the enzyme, and then additionally they can inhibit it or induce it, right? So again, this is one of those cases where it's just a substrate, it doesn't really do anything else as far as the expression or the function of the enzymes. We'll find that's not the case a little bit later with some of our things like calcium channel blockers and things like that later on. Okay, so these are just going to be affected by drugs, other drugs that would inhibit or induce the enzyme. Okay. So anyway, looking at kind of the dose response effect, so you typically will see that these drugs in combination tend to have synergism together, right? So if I can focus on two different mechanisms, I can get better LDL lowering effects than just either one alone. But just looking at an idea of what, say for instance, you're getting a statin, by itself, what kind of effects you're going to be seeing with it versus just, the HDL effects. HDL effects are okay, kind of marginal though, but not going to be the best for this. But definitely for LDL, getting triglycerides down, this is a really good drug from that standpoint. So statins are very good. If you combine them with other mechanism of action, you're going to get even better effects here. So again, there's a lot of synergy you can see with this. Okay. So side effects you can see with the statins, a lot of it can be related back to things like kind of flu-like symptoms. You can have some headaches, some fatigue, some GI intolerances. The big thing you want to watch for though is going to be the liver effects. Okay, you want to make sure that you're monitoring LFTs whenever you put someone on a statin, especially when you go really high dose sort of statins or your more elderly patients, especially those with any kind of hepatic dysfunction, right? So you got to monitor the LFTs, make sure those are not rising. Okay, yes, ma'am.
Why is that? Is that just because it's working mainly in the liver and?
Yeah, so imagine, if you're affecting the biochemistry of the liver specifically, it stands to reason you may be affecting some of these other pathways here, right? So in most patients, you don't really see that to be an issue, but some patients cannot tolerate statins at all because of maybe previous hepatic dysfunction or things like that, especially if you have drug interactions happening here. So if I have someone who's on 80 of atorvastatin and then they start drinking grapefruit juice, guess what? Those levels are going to go up and you're going to see hepatic toxicity, right? So that's going to be one of the big things that's going to keep people from being on these drugs in the long run. You can sometimes get around it by reducing the dose, and oftentimes we're going to be trying to kind of get these doses up as high as we can for statins, and then once we see that intolerance, that's when we're going to kind of back off a little bit. Okay, so you titrate up until they can't really tolerate it, either due to side effects or liver function or things like that, and then you back off a little bit, and that's where they're probably going to end up staying at. Okay. The other big thing is myalgias, right? So you can see, again, a lot of these patients may be, not really the most active individuals. Maybe they're couch potatoes, why their lipids are kind of out of control to begin with, and you're going to find that, that, man, I just feel like I just ran a marathon or something. Well, these are really hurting me. That's a warning sign, right? They need to know that this is not normal for, it's normal for the drug to occur, but that is something that should be kind of a warning sign they should call you back about, right? So again, myalgias can be just fixed by reducing the dose in some cases, but the big thing we worry about these myopathies, primarily rhabdomyolysis. Okay, what is rhabdomyolysis? Yeah, breaking down of the actual muscle, right? So how would that manifest? How do you think? What would the patient notice? What would the patient notice, right? So what are they going to be? Yeah, so again, the urine takes on what kind of color? A dark brown cola color urine. So if you ever go on like I don't know if you guys are familiar with Reddit, the website. Basically, there's like a fitness Reddit, and so once every year, usually around the new year, when you have a lot of people are getting their New Year's resolution, someone always posts a picture like, hey, my urine looks like this. Is this normal? And it's like cola colored, and you're just like, oh no, you need to go to the ER. And they're like, no, I don't have health insurance. I'll be okay. And they're like, no, you're gonna die if you don't go to the. So anyway, so it's one of those things where they need to be warned about that. The other thing is like very severe myalgias. They're going to feel like they can't even get out of bed and walk because their muscles are so sore. Very rare that it occurs, but more often when you have some of these interactions, namely through that CYP3A4 interaction. That's probably the most common clinical scenario I can think of where this would actually be a really big concern here, okay? Then again, the problem with that myoglobin breaking down, not only does that muscle toxicity, but that myoglobin, where does it get eliminated? Through the kidneys, right? We said the urine takes that dark brown color. Well, that myoglobin can precipitate out, and all of a sudden they have all this myoglobin kind of clogging up the kidneys. You can see permanent renal damage from this, okay? And you can see some patients develop, they have to be dialysis dependent afterwards. So you got to be really careful with that and just be aware. Again, if you notice these really severe myopathies, like they need to get off statins altogether, we can switch them over to a different drug if we need to. Okay. All right. So as mentioned, contraindications, particularly for developing fetuses, they need their cell membranes, right? Because they're developing all kinds of new cells, right? So you do not want to mess with lipid metabolism in those patients, okay? So statins are absolutely contraindicated in pregnancy. You cannot use them for this population. We'll talk about one class of drugs that is okay for pregnant women. Obviously, though, if we can get around not using drugs, that's always going to be preferential, right? Less drug exposure, it's always going to be better for a developing fetus there. So again, what could you do if you couldn't use drugs? Diet, exercise, right? Is really the big things you can do with that, right? Anyway, and just be careful of mixing this with other CYP3A4 inhibitors. This is a relative contraindication, meaning you may need to put these two together, but just be aware of you may need to adjust your dose with a statin to get that down to where it's not going to be an issue, or switch over to a statin that is not going to be metabolized by CYP3A4. So for instance, if I ask you on a test question, I say, hey, you have a patient who's on simvastatin, but you want to go ahead and start up, a 3A4 inhibitor, what is a safe statin to switch them over to? You do Crestor. Crestor is a good answer for in that case there. Something like, pitavastatin might be a good answer. So keep in mind those interactions. I might have 3 of them that were CYP3A4 mediated, and then the one, or maybe 4 of them would be CYP mediated, and then the one would be something like, the rosuvastatin, right? Those are a good question I could ask to see, like, do you actually know which ones are going to be 3 or 4 versus which ones are not, okay? And again, you're going to be looking this stuff up as well. I don't expect you to remember that specific fact the rest of your careers, but at least to know, oh yeah, this is based on a statin. I should probably look up this drug interaction before I prescribe them something new, right? Atorvastatin, simvastatin, and lovastatin are the big ones. They're going to be 3A4 mediated, so be careful with that. Atorvastatin and simvastatin are still used quite frequently, so you have to be cognizant of that. Other drugs that can interact with these, we're going to talk about more later on. So things like verapamil, amiodarone, these are big cardiology drugs we'll talk about later. And then some of these other agents, things like niacin, can increase levels as well. This is another anti-hyperlipidemic drug we'll talk about in just a few minutes. Obviously, I mentioned grapefruit juice. You got to be really careful with that because unless you ask the question, our patient's going to be telling you, hey, I'm drinking grapefruit juice. This doesn't come up in conversation, right? You got to ask them, hey, what do you drink normally? What do you have with breakfast? Those are good questions you need to ask them because, again, if you don't ask, you don't know, and then you can't really get that information. Okay. All right. Now, these are the most efficacious and the best tolerated out of the whole bunch here. And again, this is going to be first-line therapy when we want to get their LDL under control, right? If they have hyperlipidemia or very high cardiovascular risk, this is the drugs they're going to be put on. We'll talk about those guidelines a little bit later on to see what that looks like. Okay, up next, these other drugs are going to be useful adjuvants or useful additional agents you can add on if need be. So we're going to talk about these more briefly here. We're going to kind of go through these quick because, again, statins I wanted to highlight are just such a big deal here with hyperlipidemia. Those are the ones you really want to focus on. But these are still, you find some patients have been on these for years. You're going to find some patients may need an additional boost to their statin, and this is where these drugs can come into play here. So looking at cholesterol absorption and inhibition, this is where ezetimibe or Ezeti is going to be coming into play here. Now, this is basically working directly within the GI tract to prevent the actual absorption of cholesterol coming in both from the diet and then also the bile salts that have been released through the gallbladder are going to be prevented from being reabsorbed there as well. Now, do you remember that process I called enterohepatic recirculation? Right? It means something gets spit out through the biliary tract, can then be reabsorbed through the GI tract, and eventually get spit out. And so you have this cycle that occurs here, right? We can interrupt that cycle. And if you can interrupt that and prevent absorption, then hopefully you can prevent that further cholesterol from getting in, right? So again, if you have less cholesterol being absorbed, cholesterol levels in the liver go down, and they're going to have the same effect as what you would see with the statins, where you see that if you have low cholesterol levels in the liver, they're going to try to increase that LDL receptor expression, okay? So again, just a different way to get to the same effect, essentially. No, because the birth control is going to be, so that's a good question, right? So for everyone else's sake, estrogens also go through enterohepatic recirculation, right? So I see that interaction I mentioned with antibiotics, right? Because again, when the estrogen gets sent out to the GI tract, the bacteria in the gut help to break that down into a more absorbable component. And so that would not be an interaction here. That would not be something that where ezetimibe would prevent the absorption of estrogen. The structures are different enough to where cholesterol itself would not necessarily would be inhibited, but the estrogens would not. But you're right, because again, cholesterol eventually goes to make things like estrogen, right? Testosterone and all those different things. Yeah, so it's a very good question, but clinically I don't know that's been an interaction to worry about. Yeah. Anyway, so this is basically just trying to interrupt that cycle and then also try to prevent some absorption from the GI tract as well, just from coming from dietary purposes. So again, we're going to be decreasing that intestinal delivery of cholesterol to the liver, which means we're going to have more LDL receptors here, and that also means we're going to have less cholesterol content of the atherogenic particles we're sending out, right? Things like LDL, things like the VLDL, etc. Okay, and again, what you're going to find is that this also gets the drug itself gets enterohepatically recirculated. It kind of limits a lot of the systemic exposure. So really, from a systemic side effect standpoint, this is less than you would see with something like the statins. Okay. So not great by itself as a drug, but if you need some additional LDL lowering effects, so if you put your patient on maximal dose statins and their LDL is still like 200, like you need to still get that down somewhat. So this is where things like ezetimibe can be very useful as kind of an add-on drug. And in fact, you'll see a lot of combination drugs that may include ezetimibe plus something else like simvastatin. Now, maybe some GI-related side effects. You may see some abdominal, pain and cramping, things like that, but mostly well tolerated. And you may see some synergistic increases in LFTs when combining this with statins. So again, monitor their LFTs. Usually, you're going to monitor kind of at baseline, and you usually follow up 6 weeks, a couple months later, kind of see how they're doing. Make sure you're not going to have these rises in LFTs. Obviously, if they show up turning yellow to your clinic, that's probably not a good sign. Probably something you want to get them off of, right? Anyway. Other drugs you may find that can interact with this include things, we'll talk about some of these other ones in a few minutes here, but like the fibric acid derivatives is a class we'll talk about in a few minutes here, can potentially worsen things like cholelithiasis, right? So that's one of those things you have to be careful of when affecting cholesterol content and the bile salts coming out. If you monkey around with that too much, you can get cholelithiasis developing. So that would be one interaction to note here. Bile acid sequestrants are another group we're going to talk about in a minute as well. That can actually bind up the drug and actually decrease the half-life and get it eliminated through the feces, so that may be an interaction to worry about. And then things like antacids can decrease the concentrations. And then don't worry too much about cyclosporin. It's a drug you sometimes see used like in transplant, autoimmune conditions, but can also have the ability to increase concentrations, and does that by actually inhibiting a protein called PGP. I mentioned that it's an efflux pump that normally will shuttle things out of the GI tract or will pump things back into the GI tract, I should say, for elimination. So don't worry about that one too much, but just know that anytime you're mixing these with other lipid-lowering agents, you tend to see some increase in side effects associated with that. Okay. Next group here we have is our fibrates. So the three that fit into this category are going to be gemfibrozil, fenofibrate, and then bezafibrate. So the way that these agents are going to be working is they're actually working by activating this nuclear transcription factor. So it's actually working at the site of the nucleus, and it activates this thing called PPAR alpha. What that does is going to be increasing fatty acid oxidation, which means by oxidizing those fatty acids within the hepatocytes, you're going to cause less triglycerides to be secreted out of that hepatocyte. Okay. So again, more metabolism occurring within the liver, less VLDL is going to be escaping and getting out into the bloodstream. Okay, so that would stand to reason. What effect do you think it's going to have on your triglycerides? It's going to go down pretty significantly. So this is one of the big classes where if you have something like an isolated hypertriglyceridemia, there's some genetic factors that can predispose a person to that. Sometimes you'll just see that with an individual. This is a really good drug to get those down because of the fact that you're having that fatty acid metabolism occurring right there within the hepatocyte. Also, you're going to find increases in expression of this ApoA1 protein, and that actually increases HDL levels. So the place where the fibrates fit in is they're really good at getting down triglycerides, and they're really good at increasing your HDLs. Okay, that's kind of the main place you're going to see these being used. Looking at this, you can see triglycerides down 20 to 50%. LDL decreases, okay, definitely nothing to sneeze at, but not as good as a statin would be. Total cholesterol is going to go down, obviously, but HDL and triglycerides are the big thing that the fibrates are going to be that's their niche. Adverse effects, a lot of just abdominal stuff you're going to see here. But again, we mentioned the cholelithiasis is a big one. So that's why you see the interaction with the ezetimibe where it can actually worsen that due to its actions. The other thing as well is when because these can cause myopathies, they can also interact with the statins, which can also cause myopathies. They can kind of have some synergy there. So that you want to be careful of as well. Other effects you can see is, again, I mentioned some of them actually can increase HMG-CoA reductase inhibitor levels. That's actually not through a CYP-mediated mechanism. It's actually through a different metabolism there. But just know that some of the fibrates can actually increase statin levels. So again, very careful whenever you want to mix these drugs together. You may need to adjust your dose of statin down if you're going to be initiating a fibrate on top of that. Okay. Again, the primary place you're going to see this being used is if you have a patient who has a triglyceride level, say like greater than 1,000, that's going to be the big place where the fibrates are going to be fitting in. Again, not common you see that, but again, there are some genetic conditions that can predispose a person to that. Just be aware. Okay. Next, we have our resins. These are going to be also known as our bile acid sequestrants. So what do you think it does based off the name? sequester bile acid, right? So where are they working at? In the actual GI tract, right? Because again, they're going to be sequestering that bile acid, and then what happens to it, do you think? Poop it right out, right? It's going to go right out through the feces there. So that's the main way it's going to be doing, is binding up those bile acids and then eliminating them. They actually do not get absorbed systemically. So who do you think that might be good for? Pregnant women, right? So again, pregnant women, small children, this can actually be a good drug for them because it really limits the systemic exposure to drugs, right? And again, the less drugs pregnant women have to be exposed to, the better. Can't always get around that, but again, that's kind of a general mantra. You want to try to avoid meds whenever you can in those patients, right? Actually, it'd be nice if you could avoid meds in all patients, but unfortunately, it's not the world we live in, but it is what it is. So these are going to bind to the bile acids. They're going to prevent that intrahepatic recirculation, and they're going to allow it to be eliminated right through the feces there, okay? And again, decreasing intrahepatic levels of LDL are going to cause more receptors to be expressed at the hepatocyte level. So that's how it's going to get your LDL down from the bloodstream standpoint, okay? Some of that from the bile salts, can have an effect there, but again, it's not the main action you're going to see. This is kind of the secondary effects you see in the hepatocyte. But again, very nice from the limited systemic side effects standpoint. However, what kind of side effects do you think you'd see? Yeah, so it's going to be a lot of GI stuff, right? So you're going to see a lot of abdominal cramping, a lot of flatulence, diarrhea. Those are going to be the big things you're going to see along with that. Not necessarily. Yeah, nothing like it would like turn it black or like would turn it green or anything like any specific colors like that. Because if you think about it, like why are feces brown in the first place? Yeah, so those breakdown products are getting spit out through the biliary tract anyway. So maybe there'd just be more of those. So maybe it'd be even more. Like you really wouldn't expect to see like an appreciable change like that, right? But certainly if it's like, oh, it's going to turn your poop green, like that's something to know, right? Or it's going to turn it, black. That is definitely a big warning sign. So good thought though, for sure. The three drugs that fall into this category include cholestyramine, cholestyramine, and then cholestyramine. Okay. And so most of these come as either a very large tablet or they come as a powder. You actually end up having to mix into water or fruit juice. So from a palatability standpoint, patients don't really like it so much. So it's very kind of gritty sort of taste. It's not very palatable to your patients. So oftentimes if you can mix it in like orange juice or something a little bit more pulpy, that can sometimes cover the texture a little bit and make it more tolerable to your patients. Okay. Now, when you take these, you want to take it within 1 hour of a meal. Why do you think that is? When's your gallbladder most active? Well, probably around mealtime, right? So again, that's when most of those bile acids are going to be sent out. That's when you want to sequester them, okay? The other big thing, though, is you have to separate these from other meds because of the fact that not only do they bind up the bile salts, but they'll bind up a lot of other stuff as well. So either you want to give your other med, say like an hour before, or you need to give it like 4 hours after you give one of these bile acid sequestrants, okay? All right, you got to separate them out. Otherwise, you're going to find that binding occur, and then the drug's not going to get absorbed. So again, looking at the GI effects, you have bloating, flatulence, fullness, constipation. That's all expected because we're binding up all these bile acids. They're still sitting there in the GI tract waiting to be eliminated. So that's one of the big things you see. Now again, this isn't. Anyone remember that drug Ally that went over the counter several years ago? This is not quite the same as that. That was actually a fat absorption inhibitor. So again, it wasn't just dealing with cholesterol, but kind of all lipids. And so one of the big things you saw with that was like really, really bad diarrhea. You see, because again, all that fatty stools coming out was definitely not great on a patient compliance sort of standpoint. It's one of those things where they said, hey, make sure you bring extra pants with you. If they can be dark, that's even better. Because again, they would have things like kind of uncontrolled diarrhea, etc. It was a very effective at weight loss, but again, the side effects were kind of the limiting factor there. This is not nearly as bad as that. I wouldn't necessarily worry about my patient having excessive watery diarrhea, but that's one of those things. Hey, you're going to feel a little bit fuller. You maybe having a little bit of cramping there, so just be aware of that. Okay. And again, if you're giving these to pregnant patients, what are they feeling anyway? Kind of full and crampy anyway. So again, it's one of those things where it's like, maybe actually worsen these effects. Maybe, again, you have to have that conversation, risk versus benefits. Other things to think about, it's going to interfere with absorption of some of the fat-soluble vitamins like A, D, E, and K, interfere with folic acid absorption, right? It's important for pregnant women to get all those vitamins to make sure they're going to be able to develop that fetus appropriately. One of the other things to note here is, and this is a relative contraindication, this actually can increase VLDL concentrations, which means your triglycerides are going to go up. So if I had someone who had just a very high triglyceride level, I would not want to give them a bile acid sequestration alone because that could potentially worsen that. Okay, so just think about that from that standpoint. Also, you may see some increase in calcium excretion to do that binding as well. So again, electrolytes can be affected, vitamins can be affected. So again, you want to separate these out as much as you can from other medications to hopefully prevent any of that binding from occurring. Yes, ma'am.
Can you tell the patient to take it with prune juice, or would that be like contraindicated?
Prune juice, specifically not that I can think of. No issues that I know of with that one. Yeah, what's prune juice good for?
For constipation?
For constipation, yeah, it has a lot of like kind of big sugar molecules that are hard to absorb, and so that can increase, water content of the stools and help to increase defecation. But not that I'm aware of that would be any interactions there. Yeah. So again, just some of the drugs that can end up being bound up by these bile acid questions. It's not important you memorize this list specifically, but just know that a lot of drugs are going to be affected. Digoxin, warfarin, thyroxine, all of these can be affected and can prevent absorption. And then the question is, you can ask your patient, hey, your TSH levels are still out of whack, your T3, T4 is still out of whack, what's going on? Are you taking your medications? Or I'm taking it every single day, and you're like, I don't know about this compliance, right? But if you investigate further and get that interaction down, you can say, okay, well, I believe you're being compliant, but here's how you need to take it, right? Here's how you need to separate it out to make sure you're still absorbing that medication. Because again, if it looks like your drug's not working, the patient says they're compliant, what's your gut reaction to do? Increase the dose, right? But that may not be appropriate, right? You may need to investigate further to see how they're actually taking it, what are they taking it with, okay? Again, just from a contraindication standpoint, again, they have very high triglyceride levels, so greater than 400, or that familial hypertriglyceridemia. Avoid that for those patients. Greater than 200 is kind of relative, right? If you're giving it by itself, probably not the best drug. Maybe if you were giving it with something else to get down the triglycerides, maybe that'd be a good option. Okay, and again, these are the safest because they have very limited systemic absorption from that standpoint. However, they're probably the most poorly tolerated just due to the GI side effects from this, right? So just be aware of that. And again, do people feel when they are hyperlipidemic? Do they have any negative effects from it? No, that's the thing. It's kind of a silent disease, right? And so that's one of the things where, like, you're giving me a drug, I only feel worse. And the disease really wasn't bothering me in the first place, right? So you have to make that argument, right? That's one of the toughest things about prescribing some of these medications. Like, they're like, I didn't have a problem before. Now all of a sudden I have all these new issues popping up because of the drugs you gave me. What the heck's up with that, right? So again, it's kind of a double-edged sword. You either have that situation or you have the fact where it's like, people want drugs when they absolutely don't need it, like viral illnesses and things like that. So again, you have to be very persuasive as a physician's assistant to make sure that, you're taking care of your patients appropriately, right? You got to get that buy-in from them. Okay. All right, and another group here we have is called niacin. Niacin is actually just a B vitamin, so you can actually find some over-the-counter preparations of this. It may not be as effective or as convenient of a dosage form as some of the prescription products. However, if you have someone who's like, man, I really just want to stick with like some more natural sort of remedies or thing. I don't like big pharma. This might be a good option for them. They can go down to the GNC and get niacin-based products, and it can help out with their hyperlipidemia. So it could be a good option from that standpoint. Just keep in mind there's a lot of different forms that are out there. If you see niacinamide, that is actually not going to be very effective as an anti-lipemic. It needs to actually be niacin itself that they're actually buying and using that product, okay? Now, there's a couple of different forms. You can find niacin as an immediate release product. There's also a lot of long-acting or extended release product. The most common one we see being prescribed is going to be this Niaspan because it's a long-acting prescription-based product. And that's the reason why we like long-acting and so important for this specific drug is due to some of the side effects you can see with this. Anyone know the side effects you see with niacin? Flushing is going to be a big deal with this. I'll tell you a funny story in just a second here. Inositol hexaniacinate is also another form you may see potentially. So basically what this is doing is this is helping to decrease overall levels of VLDL. So again, triglycerides are going to be another big thing. They're going to be decreased due to the actions here. But basically what's going to be seen is this is going to help to mobilize fatty acids being developed in the adipose tissue. You're going to free those fatty acids that can be absorbed by the liver, and then you can find that you'll actually you're decreasing mobilization of free fatty acids. So less fatty acids making it to the hepatocyte means less triglycerides being formed here, which means less of it being shuttled out to the systemic circulation. Okay. So again, more of those fatty acids are staying in the adipose tissue, hanging out there, so they can't ever make it to the liver to form into new triglycerides. So just note here that the extended release preparations, and look at me, I'm even making my own cardinal, violating my own rule. I should take off points. You can count off my evaluation if you want. What's the problem here? QD. You can't put QD. It's supposed to be QD. I thought I fixed all of those, but I did not. So anyway, I know I screwed up twice. Anyway, BID and TID is totally fine. But QD, definitely not okay. So bad pharmacist. Anyway, so the big thing we shoot for is having extended release products because of some of the side effects we're going to see with this. And flushing, as some of you correctly amplified is one of the big things. A lot of this is mediated through prostaglandin synthesis, right? When you think about prostaglandins, what do you normally think about? NSAIDs, you think about inflammation, right? NSAIDs are just non-steroidal anti-inflammatory drugs, so prostaglandins form a lot of the basis of inflammation, right? So it's one of those things where inflammation, things get red, they get hot. Same thing happens to patients kind of systemically when they take niacin. So how do you think we could deal with that? Yeah, you actually give them an NSAID beforehand. So a lot of people will recommend taking aspirin beforehand. You can use any NSAID from that standpoint. Ibuprofen would be fine. But I think just kind of classically, most people just think of taking aspirin along with that. Because again, most of these patients have high cardiovascular risk, which they be on anyway. Probably should be on some aspirin anyway. So if you can kind of combine the two, it's going to be very good. Along with all that prostaglandin, they get very hot, they get diaphoretic, very uncomfortable. There's a lot of gastrointestinal upset that goes along with this, a lot of nausea and vomiting you can see with that. And just know with really increased doses, you can end up seeing some effects on the liver function profile. You can end up seeing increase in glucose, which may be bad for diabetic patients, which oftentimes these patients are also diabetic, and decreased glucose tolerance. So again, be careful with your diabetic patients. It may not be the best drug for them. So I will tell you, when I was in pharmacy school, and I was on rotations. I was in Gainesville at the time. I was at one family practice clinic, and I had some friends in my class who were also at a different clinic the other side of town. We were carpooling at the time, and so they all decided they want to do a niacin challenge. They said they want to do the immediate release niacin. They want to see just how bad this flushing actually was. I can tell you, it was very, very bad. So I ended up picking up my friend from their site, and she got into the car, and I mean, she was just red from head to toe. She was just completely, I'd never seen someone look so red in my entire life, right? Just sweating, just miserable. I think she ended up sleeping for like 18 hours after that just to sleep it off because it felt so bad. Took no aspirin beforehand. So again, it's one of those things where if you can use the extended release preparation, that slow release helps to decrease that flushing very significantly. So that's why we like this product. Do you have a question?
Yeah, no, I was going to say I had a buddy while I was in the military. He was trying to beat a distance, and he took some niacin, and I mean, he beat it because they thought he was sick, and so they sent him a sick call. But he was flushing. He was like, "My skin is on fire."
Yep. So. Yeah, very unpleasant. So that's why we need to be careful with. You also have a story. Only with the short acting. The immediate releases we're going to see that most frequently, right? Long acting should hopefully help to mitigate that very significantly. They still have some intolerances. That's where aspirin can be useful along with that, right? Again, the key story or key point to that story, just don't do drugs, right? Then you don't have to worry about trying to pass your urine drug screens. Just a thought. Anyway. So again, be careful with niacin if you have chronic liver disease. Again, that can worsen your LFTs. If you have patients with a history of gout, may not be the best drug for them due to the hyperuricemia. If they have glucose intolerance due to diabetes, again, that may not be the best drug for them. But this is very good at getting triglycerides down and getting your HDL up. Okay. Again, talk about some of these interactions here. Ethanol actually can increase the flushing as well, so it's definitely not one I want to mix along with those, right? Okay, as I mentioned, useful for patients if, again, if they're not getting their LDL down to goal with statins alone, or if you need to get the triglycerides down, get the HDL up, these can be good drugs for that. So these kind of fit a similar role to the fibrates if you think about their actions, essentially. So again, we like things like combination drugs because again, if you're not able to get your lipids under control with just one drug, this is where combination products can be very useful. So for instance, if you mix something like niacin plus lovastatin, right? So mixing those two together, you get more synergistic effects than just either one of them by themselves. Can be very useful. Also, what does that do from a compliance standpoint? It's better, right? Because then they only have to take 1 pill a day versus 2. That's always going to be more, easier for them to remember.
Is it going to be significantly more expensive for a patient? We just tell them to take a statin and then take over the counter. Well, yeah.
Yeah. So if you go to the GNC and buy a dietary supplement, yeah, it depends, right? So again, anytime you have a company that comes through and says, hey, we want to put these 2 drugs together, guess what? They get a brand new patent on that. They have to go through the whole FDA process. So when they do that, yeah, for a while it is significantly more expensive. So question of does the patient's insurance cover it? Is it relatively cheap or no cost to them if they go through insurance versus the only way they're going to get it is if they go and buy stuff from the dietary supplement section, and if I give them the statin. So it just depends. Again, it's always going to be a risk benefit cost analysis when you're doing this sort of thing. But yeah, a lot of times combination products usually are coming out after the original products and can tend to be more expensive just due to the fact they're still on brand, right? They're still patented. Okay. So looking at the individual drug classes here, you can get an idea for kind of their general effects. The numbers aren't the specific things I want you to memorize, but just generally look at statins. Good for getting down total cholesterol, good for getting down LDL. Okay, effects on HDL and triglycerides, right? As compared to things like, the fibrates, things like nicotinic acid. They're okay for total cholesterol, but the main thing you're going to see is bumps in the HDL and decreases in the triglycerides, okay? So again, in adding two different classes together, you can get synergistic effects here. They work better than either one of them by themselves. However, you also have to worry about toxicity, right? We already saw there's a lot of interactions with these drugs. You may need to adjust your doses just to get to the point where they can actually tolerate the medications. Okay. So looking at your lipids, typically how you're actually going to be monitoring this is obviously looking at things like the LDL levels. You're looking at your triglycerides, your HDL. Normally, if you're looking at how to actually calculate that, in order to get an idea of what your the triglycerides are basically just a surrogate for what your actual VLDL concentrations are. And I'm not going to have you calculate this on a test. I just want you to see kind of what goes into what is a total cholesterol, right? So it's your HDL, your LDL, and then typically your triglycerides all added together, right? So by adding those up, you can get an idea for, okay, well, where are their total cholesterol levels at? Because you can have someone who has like a really high HDL concentration, but that may lead their total cholesterol to be high in and of itself, but may not be a problem, right? If everything else is under control, just because they have a high total cholesterol may be okay, right? So sometimes you have to kind of keep that in mind. But old guidelines, old things we used to use was the ATP3. This is where they said, hey, we want to make sure we get their LDL down as low as we can, less than 100 if we can. We want to get their HDLs up, right? We want to get their total cholesterols down, their triglycerides down. Nowadays, realize that the numbers themselves aren't quite this so important thing to focus on. What we do want to do is, and this was from the American Heart Association back in 2013, is that, hey, we want to make sure that we are dealing with this cholesterol, but the main thing we want to do is decrease risk for cardiovascular death. Okay, so that's the main thing they're focusing on, not just the numbers, but what the doses they've seen are that lead to decreased cardiovascular death. So basically what they say is they want to either initiate what they consider to be moderate intensity or high intensity statins for any patients that fit into 4 categories. We'll show those categories in a second here. But again, we're not really shooting for a specific LDL goal. We just really want to get them on as intense of a statin as we can, because we know that the higher we drive those doses up, as the patient can tolerate, the more likely we are to get those nice pleiotropic effects, the more likely we are to hopefully decrease their chance for mortality in the long run, right? Does that mean they're never going to have a heart attack? No, but hopefully we can decrease their chances, right? And one of the big things you're still going to do, you're still going to measure their lipid profiles, but it can be one of those things where you can help them monitor for things like adherence, right? So again, if they are on 40 milligrams of rosuvastatin, is probably one of the most maximal doses you can be on a statin, and their lipids have not changed at all, they're probably not taking that drug, right? It's like, giving someone meropenem, as I mentioned, that's kind of like the gorilla cylinder, like rosuvastatin high doses, like kind of like that. Like it should definitely do something to your LDL, and if it's not working, that usually means either they're not absorbing it, which is unlikely, or they're actually just not taking it, which is more common. So anyway, the 4 major people who are the types of people are going to benefit from a statin. People who have already clinical atherosclerotic cardiovascular disease. What does that mean? Who do you think that is? People who've had an MI. People with angina. Like people who've already evidenced that they have issues with delivering oxygen supply to the heart. Okay, those are the biggest group. Obviously, they're going to be benefiting from this. People have LDL greater than 190. Those are individuals that are also going to get some benefit from getting their lipids levels down. Even if they don't have evidence of cardiovascular disease, they're still going to benefit by getting those LDLs under control, right? And again, is LDL of 190, is that just due to diet? Genetics plays such a big role here, right? So again, just keep in mind, you can have someone who has a perfect diet, but they can still have a high LDL due to their genetics and just how their livers function. So based on that, you need to keep in mind that, diet can help a lot. Not going to be the only silver bullet here. But other people, so individuals who have diabetes, specifically type 2 diabetes here, going to get the most benefit, especially if they have elevated LDLs, even if they do not have clinical cardiovascular disease kind of documented already, right? And then individuals who have this risk of developing cardiovascular disease of greater than 7.5% in the next 10 years. Okay. It already sounds pretty low. 7.5% doesn't seem all that often, but we'll look at how we calculate that in a few minutes. I'm not going to have you calculate that specifically, but just know that that's a calculation you'll do to determine, okay, well, as my patient, how big of a risk are they at developing cardiovascular disease over the next 10 years? If it's greater than that 7.5%, they're going to get benefit from a statin as well. So just an idea of what the kind of the algorithm would look like, kind of the stepwise process you would take. You say, okay, well, they already have history of disease. Okay, well, yes, they do. They need to be on a statin, right? And what you're going to notice here is that the older the patients are, typically the less likely they are to tolerate really high doses of statins. You're more likely to see the hepatic issues that pop up here, the myalgias, etc. And so, for instance, if you have someone who's greater than 75, then you can kind of bump it down and use like a moderate intensity sort of statin here, right? If they're less than 75, they can probably tolerate it, and you kind of work them up to as high a dose as you can. We'll look at some of those doses in the second here. But again, high intensity statin, right? Because we know they've already had a history of disease. We want to make sure that we prevent that from getting any worse going forward, right? If not, let's say they just have an LDL greater than 190. Yeah, they need to be on a statin, right? And again, we're shooting for high intensity statins. We'll see what that looks like in a second here. They have diabetes between 40 and 75. If yes, yeah, they probably need to be on a statin, right? We also look at their risk as well. If they have greater than 7.5%, they need to be on a high-intensity statin. Okay. And again, if I have you a test question, I'm asking you that you need to be on moderate or high intensity. I'm going to make it pretty clear what it is. Like, patient just had a heart attack. What should they be on? Right? Or a patient is 24, has no previous health issues, and their LDL is 100. What do they need to be on? Probably nothing at that point, right? So again, don't make it very clear cut on the test.
You said if a patient had a heart attack and need more than 75, so do we still give moderate or do we give?
They probably should, you want to see what they can tolerate, right? You know, so I'd probably start them on a moderate dose, and then if they could tolerate it and go higher, then yeah, I say go for it, right? Again, all dependent on very case-by-case basis for sure, yeah. And then you'll do the calculation to kind of figure out what their risk is over a 10-year period, and if it's greater than 7.5%, then again, you're going to pop them on a statin there, right? So how do you figure that out? Well, some of the things that go into it, male versus female, like who's more at risk? It kind of stinks, but we're more at risk, right? Systolic blood pressure, obviously higher should be worse, right? You're putting more strain on those endothelial cells, right? Age, the older you are. Are you receiving treatment for high blood pressure, right? Because that automatically means you're hypertensive. Race, the Caucasian, black, you know, anything like that. Total cholesterol, HDL. Now again, HDL, if it's low, that would be a risk factor versus if it's high, that's actually more protective there. You have diabetes. Are they a smoker? What do you think smoking does? Yeah, it's going to increase your risk pretty significantly there. So again, if you add up all these things, you calculate it out, say, hey, greater than 7.5%, you need to be on a statin, okay? So just to give you an idea what that looks like, notice here, for the high-intensity statin groups here, you really only have two options, atorvastatin or rosuvastatin, okay? These are kind of the maximal doses you can get someone on, basically. When you get into the moderate intensity, you have a lot more options here, but keep in mind, you have to think about things like the drug interactions, right? You know, so if I have someone who's on a CYP3A4 inhibitor, simvastatin is not a good option for that patient. If I get them on atorvastatin, that's not a good option either, right? So rosuvastatin could be a good thing there, or, you know, pitavastatin or something like that. But just know your options kind of open up as you get lower in intensity. To the high intensity, you need rosuvastatin or atorvastatin. Those are the only ones that have been documented to show they have like kind of the most potent effects at their recommended doses. I'm not going to have you know the dose specifically, but just know that those are the two big ones. They're going to be considered high intensity. Now, can I use a lower dose of rosuvastatin and get a moderate intensity effect? Absolutely, but again, it's all titrating based on what the patient can tolerate from a dose standpoint. Okay, make sense? Okay. So anyway, and just real briefly, before I let you go on break, there is a new class of drugs that are out there. This is actually called a PCSK9 inhibitor. Notice here, what type of drug is this? What's the dosage form look like? It's a pen. It's actually an injection, right? So this is actually an antibody. We have the monoclonal antibody, okay? And you can know that based off the names of the drugs, right? We have alirocumab, we have evolocumab. They're actually antibodies that will target this PCSK9 protein. And this protein is actually responsible for the degradation and metabolism of LDL receptors. So if I inhibit that, if I have an antibody that goes and binds up that protein and activates it, guess what your LDL receptor concentration does? Going to go up pretty significantly, in fact. So you're going to get a ton of new LDL receptors that are there because they're not getting metabolized, and you're going to find that you have very, very potent LDL receptor, LDL concentration reductions. And in fact, in some patients, they even have undetectable LDLs on their labs, right? I've never seen undetectable LDL, but some patients in studies actually had that. Now, is that a problem? We actually have no idea, right? This is probably the first time people have ever really seen that. So we don't know if clinically there's an issue with that long term, but it's one of those things you may see. Typically, these are good for patients who have cannot tolerate statins. They kind of failed other things. They cannot tolerate it. This may be a good option for them. It's still very, very expensive, and it's an injectable. So again, obviously, this is less good from a patient compliance standpoint, tolerability sort of standpoint. But just know these are some of the new drugs that are out there you may see being used, and who knows, 10 years from now, this may be the gold standard. Who can say, right? Yeah, it'd be sub-Q injection, right? So it comes as a pen, and you can just put a pen needle on there and just inject it like you would like an insulin pen or anything else like that. But again, who might that be a bad dosage form for? Not? people have issues with their hands, right? So osteoarthritis, rheumatoid arthritis, if they have cognitive impairment, then maybe they can't coordinate injecting themselves effectively. So think about that. Do they have someone that can inject it for them, etc.? So all things to consider. Needle phobic people, they probably don't want this drug at all, right? These are all things to consider. Okay, so any questions on that first section there?
From what I've read in the past, I want to make sure it's right so that I don't tell people the wrong thing. CoQ10 for statins, can I help with that to help inhibit the whole like myalgias and stuff?
I don't know that I've seen any evidence to say that CoQ10 would inhibit myalgias effectively or reliably. I would have to do some more research on that.
Okay.
That's a good question though. Imagine if you had to do like a research project. So you could do as a lit review. You can go and find, okay, has there been any evidence to show that supplementing statins with other say dietary supplements has helped to improve the lipid profile function or things like myalgias and whatnot? That's a good research question.
And the second question is, I was told that Lovalo, or is it Lovalo, the Lovis, L?
Yeah, lovastatin.
That that one is the least likely to cause the myalgias. So if someone was complaining like they had like cramping in their legs, that we can see if they tolerate that better.
Yeah, so if you look at the spectrum of the statins and looking at like kind of the most potent being like atorvastatin or rosuvastatin, lovastatin is kind of on the wimpy end, right, with like fluvastatin. Yeah, so it'll be less likely to cause myopathies. It's also less likely to actually get your LDLs under control, right? So it's one of those things where like, well, I can switch you to a different drug, or maybe I can try titrating down on the dose of the one you're actually on, right? Yeah. So if you're on rosuvastatin 20, maybe I can try rosuvastatin 10 and see if that improves it. Yeah. Well, I mean, it's not necessarily going to help the myopathies because, again, it's not necessarily an issue with the muscles. It's the effect that the drug is having on the muscles, right?
Yeah, but I'm saying because most likely their cholesterol probably will go up with a lower dose, right?
Yes. Yeah. So you'd have to figure out another way to kind of get around that. So either introducing another medication or lifestyle modifications. But again, what's the problem with lifestyle modifications with these patients?
They're probably not doing it in the first place.
Right, it's hard for them to stick with it, right? Because again, lifestyle modifications are hard, right? It's easy to take a pill. It's hard to get up and go exercise. So because of that, a lot of those end up failing. But we would always recommend, yeah, absolutely, get up, get moving around, do some exercise, do anything, right? Because again, it's going to help them from a multitude of standpoints. So, yes, ma'am.
Why do the myalgias occur?
Probably due. Again, I'm just kind of speaking just out of random thoughts here. Probably has something to do with cholesterol synthesis within the actual muscles themselves. Maybe if you're not able to synthesize those maybe something to do with cell membranes not being able to be synthesized correctly, and then you have breakdown of that muscle tissue there. I don't know if there's any like kind of agreed upon mechanism for why that occurs. Again, that's another good research question. I have no idea what's been put out there. A lot of times we see these side effects and we're like, well, we think it maybe is due to this, but we have no idea. Yep. Yes, sir.
On your test, if you say you have a patient with an MI, are you going to expect us to know the dose for the?
Not the dose specifically, right? Just know like which ones kind of fall into like the high intensity versus like a moderate intensity sort of effect here, right? So again, it's one of those things where I could say, oh, also, I could ask a question like, hey, patient was on high intensity statin and they were taking rosuvastatin 20, right? If I give you a dose on there, just assume it's correct, right? So if I say they're on rosuvastatin 20, this is a high intensity statin, I'm not trying to trick you with that, right? But I would say, hey, they're developing these myalgias, they just feel really crummy, what could you do about that? You say switch them to a different drug, or maybe decrease the dose, or maybe I say they were on this other medication. You can maybe say take them off of that medication. There's lots of different options you can see with that, but I would definitely give you that information. I don't expect you to know the doses right now. Any other questions? All right, take a 10-minute break. We'll come back and then get talking about hypertension. Does anyone have any questions from the first half? No, fantastic. We're going to keep moving on. Now we're going to get into our antihypertensive agents here. So first off, let's talk about some diuretics. What do diuretics do? They make you pee, right? They increase urine flow. How do they cause increased urine flow? They're working through the kidneys. They work in the glomerulus and another place. No, where do they work?
You excrete sodium, so water follows.
Perfect. You excrete sodium and water follows. Wherever salt goes, water wants to follow it, right? Just via osmosis. So this is the biggest thing you're going to find with the diuretics. They prevent sodium reabsorption. Okay, we're going to see how they work in different places and their different actions, but at the crux of it is the fact that you're blocking sodium reuptake, which means you're going to lose more water along with that through the urine. Okay, and again, why do we care about diuretics? If you have too much fluid, where does it like to go?
To the lungs.
To the lungs is a big place. That could be the deadly place, right? Where else?
Legs.
The legs and the periphery, right? So again, these are all big things we have to worry about. Make sure volume overload is not an issue. And then if we have too little fluid, what can happen? Hypovolemia, hypotension due to that, right? So again, you can not perfuse well if your intravasculature is not adequately filled, right, with volume. So again, you have to keep this delicate balance here. Make sure you're not using too much, losing too much, or keeping on. Anyway, the kidneys, highly oxygen dependent. They receive a lot of blood flow and they require a lot of oxygen because of the active transporters they have. In order to make sure all this absorption and secretion, all these different things are occurring effectively, you need oxygen, you need ATP. This is why the kidneys are so sensitive to things like decreases in blood flow. You decrease blood flow to the kidneys, you decrease oxygen delivery, what happens? Those kidney cells start to die off, right? So again, this is why kidney injury can be such a big deal, and why things like sepsis are such a big deal with kidney function, because they cause decreased perfusion, all these different things. So you have to really think we want a lot of oxygen blood flow to the kidneys because they're so important here. Also, if the kidneys are detecting things like they have low pressure or they have low flow, what gets activated because of that? The renin-angiotensin-aldosterone system. That's going to be huge here. We're going to talk about that a lot with hypertension here. But other things you're going to see, things like atrial natriuretic peptide, right? You're going to be influenced with this. Things like antidiuretic hormone get influenced with the kidneys. All of these are going to be really important. So it's important to get an idea. If I affect one thing, what are the downstream effects? What are the secondary, tertiary effects I'm going to see after causing that change to occur? And we're going to talk about all of those here in just a few minutes. So again, looking at the kidney, we have our nephron here, and I'm sure you guys have all covered this before, but I'm going to talk about it just in terms of how our diuretics are going to be working. Note here the blood flow is going to be coming in. Note we have both an efferent and an afferent arteriole. Which direction is blood flowing in through? Which arteriole is it going through? It goes into the afferent and comes out of the efferent. Perfect. Remember that because that's going to be important for a lot of our drug actions, right? Especially when you think about things causing decreased kidney function, that's critical to know. So it's going to get filtered through the glomerulus. The glomerulus is nice and allows a lot of things to be filtered through. In the first place, it's going to hit that PCT. This is where most of the absorption is going to occur, right? So most reabsorption occurs in the proximal convoluted tubule. Okay. After that, we're going to have the loop of Henle, right? What does this do for us? It's a major site for sodium reabsorption, right? This is what allows us to concentrate the urine effectively, is by getting very high concentrations of sodium out here in the interstitium. And that allows us to, and again, I'm not going to get into the whole process, it's more of a physiology topic, but just know that's what allows us to get concentrated urine. It's what helps us to either make it more dilute, more concentrated based on that loop of Henle. Then you're going to have the distal convoluted tubule, and then finally we're going to have the collecting tubule here, okay? Again, we're going to find that diuretics are working at different sites, and it's important to know where they're working to see what kind of actions they're going to have, okay? So anyway, as I mentioned, filtration is going to happen here at the glomerulus. This is where things like glucose freely filtered, right? However, do we have a lot of glucose in our urine typically in healthy individuals? No, because it gets reabsorbed, right? Proximal convoluted tubule is going to be big for that. Now, who might not reabsorb all that glucose? Diabetic. They may have so much they overwork those transporters, right? They oversaturate them, and that's where you have that urine come out full of sugar. Bicarb, amino acids, all these things can be filtered very easily at the glomerulus itself, right? As I mentioned, the proximal tubule, most filtrate gets reabsorbed here. So most of that bicarb, most of those amino acids, most of that glucose, all that good stuff gets reabsorbed right there. There still, though, is a decent amount of sodium, chloride, potassium, magnesium still within that filtrate there that's going to be getting over to the rest of the part of the nephron, okay? Within the loop of Henle, this is where we're concentrating urine. You're going to find that as you go down the loop of Henle, it's going to be very water permeable, but the place we really care about it from a diuretic standpoint is right here where sodium gets reabsorbed. Imagine if I inhibit that reabsorption of sodium, where does that sodium stay? In the tubule, and then where does it go? Eventually out is urine, right? And where it follows sodium? Water, right? So you're going to find that loop diuretics are very, very good at getting rid of fluid. They're very, very potent, okay? Next, we have the distal convoluted tubule. This is also really important because you're going to find that this is where the juxtaglomerular cells are going to be. This is where you're actually having that communication here with the rest of the nephron saying, like, hey, we don't have enough salt here, right? We don't have enough pressure here. This is where you're going to get those renin-angiotensin system effects really happening, where you get those kind of compensatory mechanisms to try to get renal blood flow back up, okay? Also, you're going to find this is where our thiazide diuretics work, and you're going to see a little bit of aldosterone effect here as well. And then the collecting duct, this is where the primary site of aldosterone is going to be. Anyone know what aldosterone does in the kidneys?
Increases sodium,
So it causes sodium reabsorption, and you lose potassium. Right, so again, if I increase sodium reabsorption, water follows, and I want to hold on to more things, right? Remember what we called aldosterone? We said there's a glucocorticoid like cortisol, and then what's the other half of that? The mineralocorticoid. Think mineral, think salt. This is what aldosterone is doing, right? It's trying to help us to regulate our volume status by increasing the amount of water we're reabsorbing the collecting duct, right? Because that's the site right before it's going to enter into the rest of the urinary system, we're going to lose it, right? Once things get through the ureters into the bladder, you can't reabsorb it at that point. So aldosterone is very, very important from that standpoint. Okay, you're going to reabsorb sodium but lose potassium. Okay, that's why you see people have hyperaldosteronism. Guess what? They're hypokalemic because they have all these issues here where they're losing so much potassium. And then ADH. ADH is going to do what? More water reabsorption. ADH stands for antidiuretic hormone. What's another name for ADH? Vasopressin, yeah, vasopressin is the other big name you'll see. So if you ever see vasopressin being used for blood pressure management, that's what we're using is ADH basically. ADH is going to cause aquaporin channels to be expressed in the renal tubule, which allows for water to be reabsorbed because it's a very important thing as well. Again, remember when I talked about alcohol, why do you, when you break the seal, if you ever drink alcohol, not that you guys would do that, but if your patients ever drink alcohol, what happens to their urine flow? It goes up significantly because you're actually decreasing ADH secretion from the brain, right? So again, all these things are going to be playing a role here, right? You get such a bad hangover because you're dehydrated, right? So you want to play the water game. Not that you would do that, but tell your patients to play the water game. Anyway, so first off, we're going to talk about the loop diuretic. We're going to kind of go from potency of most potent diuretic to least potent diuretic, just in terms of causing urine flow, right? So loop diuretics are going to be the most important ones here from a volume standpoint, right? These are not the best antihypertensive drugs. In fact, these are pretty crummy antihypertensives long term. What you're going to find is they're going to be blocking the sodium, chloride, potassium reuptake pump in the loop of Henle. This is in the ascending loop of Henle that is impermeable to water, but yet these transporters, they're going to be reabsorbing sodium, chloride, and potassium. So if I block that, I have more sodium, chloride, and potassium there in the renal tubule. It's going to eventually draw water with it. It's going to flow out and then turn into urine. Okay. That also means that my sodium levels are going to probably go down a little bit, but what else is going to go down? Potassium. Now I'm going to stress potassium quite a lot here because we're going to find that some drugs will lower it, some drugs will increase it. You need to know what these drugs are doing to potassium levels because you can kill somebody with potassium, right? And in fact, when you have someone undergo lethal injection, what's the last drug they get? Potassium chloride. Very, very important because that can stop the heart. So you need to make sure patients have enough potassium to make sure their heart is going to be functioning effectively, right? And again, who are we giving these loop diuretics to? Usually patients with heart problems, right? CHF, patients with arrhythmias. If you script their potassium levels, you can kill them. So that's why I'm going to be stressing this. You got to monitor for those potassium levels, and this is a big thing here. Loop diuretics, in fact, most diuretics are going to decrease potassium levels. We'll talk about some that are considered potassium sparing. Those will increase potassium levels. We'll look at those a little bit later, but it's again good to know which ones are going to do what. Okay. Anyway, the loop diuretics we have here include furosemide. Most people have probably heard of this. It's called Lasix is the brand name. Anyone know why it's called Lasix? Lasts about 6 hours. Good. So if you ever see like QID dosing or Q6 hour dosing for Lasix, that's generally about how long that drug is going to last for, right? So that's why we get that name from. We have bumetanide or Bumex. We have torsemide, Demodex, and then we have the last one we have here is called ethacrynic acid, just to be different. Typically, this gets used if you have patients who are allergic to furosemide or cannot receive other loop diuretics. Ethacrynic acid can be used as kind of a backup. So probably used the least frequently, but can still be used occasionally. Okay. So anyway, so imagine here you have the lumen of the renal tubule, you have the urine here, you're going to have the interstitium here where the blood is, and here's your renal tubular cells, right? You're going to find that this is going to, normally in the ascending loop of Henle, you're going to have sodium, potassium, chloride being reabsorbed. This is where I'm going to block this, right? I'm going to shut that pump down, which means more of it's going to stay out here in the lumen, which just means I'm going to have more of it being excreted out in the urine, okay? This also means I can have things like magnesium and calcium not being reabsorbed here as well. So I'm going to be losing magnesium, I'm losing potassium, I'm losing calcium. All these electrolytes are going to be lost when I'm applying a loop diuretic. Okay, doesn't mean I'm going to completely deplete the patient of all those electrolytes. No, it's all within the dose, how much I'm giving, how frequently I'm giving it, but you will see those shifts. You will see that you're losing those electrolytes. Okay. So again, major action here. A lot of yes, ma'am.
So you might just explain this.
No, go ahead.
But when the patient is on a loop diuretic and he's depleted from all these minerals, do we give them something?
If he's what?
His minerals are being depleted.
Yep.
Do we give them something to counter it?
100%. Yes, you absolutely have to replace that potassium they're losing, right? Because if you don't, that's when you're going to run into issues. So again, if they're starting at a potassium at 3.5, and then all of a sudden you get them down to 2.9, like you need to fix that. It's a big thing. So either you'll have standing orders for electrolyte replacements. You know, I've worked in some places where nurses will have a protocol they follow where it says, hey, you monitor the potassium. If it comes back as this is what you order, right? Sometimes you'll fix it in TPN. Sometimes you'll fix it in, you know, all kinds of different ways to do it. But yes, absolutely. Sometimes other drugs will fix the problem for sure. Anyway, but we're decreasing sodium reabsorption, so you're going to be causing a big increase in urine output, about 4 liters a day in some cases. But just know you're losing calcium, magnesium, potassium as well. Okay. Very good at getting rid of fluid though. Okay, so if you have someone who's very edematous, you have someone who's having a CHF exacerbation, they've been steadily gaining weight throughout the week. Maybe they had they went to, you know, somewhere like a nice barbecue, and they had a nice salty food, and all of a sudden they're holding on to all that salt, and all that fluid stays along with it. They're going to have CHF exacerbation, right? So you got to get rid of that fluid by getting rid of that salt. That's where this furosemide is going to come into play here, right? But think about other actions we're going to have. These are the compensatory mechanisms we're having here. We're losing a lot of salt. We're losing a lot of fluid. The kidneys say, whoa, wait a second. We want to hold on to this. We want to make sure that we're keeping things kind of at homeostasis here. So some of the things you're going to find, you know, due to the hypokalemia, you're going to see things like impaired insulin release. Who's that bad for? Diabetics, right? So you're going to see glucose intolerance associated with this. Not only that, but one of the compensatory mechanisms the kidneys have is to increase activity of the renin-angiotensin system, but also increasing the sympathetic nervous system, right? So increasing release of things like norepi and epinephrine, which causes, you know, with the beta-2 effects. You can see increases in glycogenolysis. Glycogenolysis leads to gluconeogenesis and more glucose, right? Alpha-2 activity can inhibit insulin release, right? So you're seeing some, you know, glucose intolerance because of this. You can see some systemic vasodilator actions. Just know that when you have the kidneys being, you know, losing all this fluid here, one of the things it wants to do is try to increase perfusion to the kidneys. It says, well, I don't have enough flow here. Let me get more flow. And so one of the things it's going to do is try to dilate the afferent arteriole. Right? It said the afferent's one coming in. So if I can dilate that, it means more fluid's coming in. It means you get more filtration happening. Right? So how does it do that? That's where prostaglandins come in. Right? Prostaglandins are vasodilatory there at the afferent arteriole, so you dilate that out, get more flow coming in. But what could interact with that? NSAIDs. That's why you see NSAIDs can decrease renal function in patients who have renal disease, because they're really relying on that prostaglandin to cause that dilation to occur. So they lose that. Guess what? That afferent arteriole clamps down, filtration goes down. Guess what? GFR goes down. Their creatinine clearance goes down. No good. That's why you see the NSAIDs can cause an acute decrease in kidney function for these patients that really need those prostaglandins around.
So you said prostaglandin causes vasodilation?
Of the afferent arteriole.
But NSAIDs can block it?
Yes, so NSAIDs of them block that, so you have less prostaglandins, so you see constriction of that vessel there, right? So other things, increase activity of things like the renin-angiotensin system. We'll talk much more about that in depth in a little bit later here. You'll see increased aldosterone activity. And again, think about it. The loop of Henle is losing all the sodium. Eventually, towards the collecting duct, what will aldosterone do? Increase sodium reabsorption. So it makes sense. That's why the kidney's trying to compensate. It's like, well, wait a second, I'm losing all the sodium here in the loop. What if I can try to reabsorb it in the collecting duct? It's try to compensate for that. This is where you're going to find that in some cases you can develop what we call loop resistance, where your loop diuretic will lose efficacy because distal parts of the nephron are trying to keep up the pace, right? They're trying to compensate for that. So this is where sometimes you'll see multiple diuretics being put on together because they can work synergistically. And so say, for instance, I have a loop diuretic plus an aldosterone antagonist. That way I can help to hopefully keep that sodium there in the renal tubule and eliminate it as urine. Starting to see how complicated the kidneys get. You'll see that even more when we get into that section in the last part of this class here. But anyway, other things you're going to see, increased antidiuretic hormones. You're going to try to hold on to more of that fluid there. Yes, sir.
If you're trying to lose more fluid through renin-angiotensin system, but then increase ADH indirectly increase the volume again. So is it like renin-angiotensin is more than ADH? Maybe that's why?
It depends. It's all kind of a balancing act. I mean, you're going to find that depending on what drugs are on board, you're going to be inhibiting different systems here. But in general, these are the systems that are going to get kind of upregulated. In these cases, we're trying to get rid of that fluid. And again, we can try to overcome that with things like, you know, aldosterone antagonists or diazide diuretics or things like that. But again, a lot of it is due, you know, how do we titrate our doses? You know, can I increase dose to overcome some of these effects? It all just depends on the patient. Yeah. Anyway, other big things you're going to find, uric acid levels tend to increase because, again, if you're losing fluid, you tend to concentrate what's in the blood itself, right? So it's called this kind of contraction sort of effect here where things in the blood get more concentrated. And so for patients who have uric acid issues, you can see that it can contract that and cause more precipitation to occur. It can increase gout in patients who have the history of that. So just be aware of that. You see a mild metabolic alkalosis and kind of a limited concern here, but certainly things like hyperlipidemia can be increased because, again, you're increasing that sympathetic nervous system activity here. And then also we're going to find that, you know, effects in trying to regulate GFR through the angiotensin too. We'll talk more about that a little bit later on, but just know this is also some of the other effects we'll see with these loop diuretics. Now, one thing to note as well is when you have patients with really poor kidney function, which diuretics you can actually use. Some of them are going to lose their efficacy when you get down to really low creatinine clearances. What's like a normal creatinine clearance? It's like around 100. Let's say 100 mLs a minute could be considered a normal creatinine clearance. And again, you're going to get a feel for that as you go on. You see these values more and more. You kind of get a feel for like, okay, that's pretty normal, or that's not normal. When you get down less than 30, that's an abnormal, right? That's someone who has poor kidney function here. The loop diuretics will still remain efficacious. So even if they have almost no kidney function, I can still give them a loop diuretic and still get an increase in urine output. Okay. Now, just because I'm getting urine out of the patient, does that mean that the kidneys are functioning? No, it just means they're getting fluid out of them. Does not mean the kidneys are actually working all that well. Okay. But loop diuretics will retain efficacy even at very low creatinine clearances. Not necessarily. It's just more of an issue of they still probably have some flow occurring. It's just a matter of getting that sodium to kind of prevent it from being reabsorbed in those cases there. I don't know if it may have a little bit to do with the prostaglandins, probably not the major action there, right? Now, where do we use loop diuretics? Anytime you want to get rid of fluid, a loop is going to be a good option here. So if you have pulmonary edema, this will pull fluid off the lungs, right? If you have cirrhosis of the liver and you're developing ascites in this big, massive abdomen, that's what will get rid of some of those fluids there. Heart failure, renal failure, hypertension. Now, again, these are not going to be good long-term for hypertension due to those feedback effects, right? Due to things like the renin-angiotensin system getting upregulated there. So these are good if you're having a patient maybe coming into the ER, they have an acute hypertensive sort of situation, and you notice they're fluid overloaded. This can still be a good thing because, again, if the vessels are so full of fluid, that's what's causing the hypertension. Getting rid of some of that can help to release some of that pressure. Okay. So we already talked about some of the adverse effects here: hypokalemia, hyperglycemia, things like hyperuricemia. All those things we've kind of already talked about already. But other things you want to think about: ototoxicity. Okay, these can damage the hair cells. What other drugs have we seen that can cause ototoxicity? Vancomycin, aminoglycosides like gentamicin, right? What effects do those have on the kidneys? They can have nephrotoxicity as well, right? So again, you're seeing, okay, well, if I cause nephrotoxicity in my patient because they're on aminoglycosides and vancomycin, they have the renal dysfunction, and now they're not getting rid of fluid. Let me put them on something to get rid of that fluid. I'm gonna put them on a loop diuretic. Guess what? I got even more ototoxicity, right? So you can see how these things can kind of compound on one another if you're not careful, right? Just throwing more drugs at a problem very frequently is not going to be always the right answer, right? Fewer drugs is always going to be better in my eyes, right? It's not job security for me necessarily, but it just means it's going to be better off of the patient overall. Okay. Again, hyponatremia can be seen here. Again, one of the big manifestations for hyponatremia is altered mental status and seizures, so you have to be really careful with that. And then other things, maybe some allergic reactions, pretty rare though. As I mentioned, increases in BUN can be seen as well. Okay. So other drug interactions, as I mentioned, the NSAIDs. NSAIDs are going to blunt the natriuretic effects here. When I say natriuretic, what does that mean? Peeing sodium. Specifically, right? So natriuretic means it's going to pee sodium, and so you're going to see some blunting of that blood pressure effect there, right? So again, be careful with that. Obviously, as I mentioned, aminoglycosides can potentiate that ototoxicity. Vancomycin could have been put on here as well. And again, anything that is going to be primarily renally eliminated can have some issues where you're going to see that maybe those drugs don't get eliminated quite so well anymore. So for instance, lithium. Lithium is a very small metal. Lithium looks actually a lot like sodium. If you look at them on the periodic table, they're actually very close to one another, and they get treated very similar in the kidneys. What do we use lithium for? Bipolar disorder, right? So we use it for bipolar disorder. It's one of those things where if you put the kidneys in the state where they want to hold on to sodium, and in this case we are because we're giving them a loop diuretic, right? As I mentioned, later parts of the kidney say, I want to hold on to that sodium. Guess what you also hold on to? Lithium as well. You can see very severe toxicity. I've seen several cases of seizures precipitated by high lithium levels due to someone being put on a diuretic, right? So it's not entirely uncommon. Anyway, so just be aware these drug interactions are going to come up. We'll talk about digitalis later. It's an antiarrhythmic. We'll sometimes use for AFib and CHF. We'll mention that in a later slide set. Anyway, So those are the loop diuretics. The next major class we're going to see being used here are going to be our thiazide diuretics. We're going to have things like chlorothiazide, of hydrochlorothiazide. Anyone know what that gets abbreviated to? HCTZ. I had one patient come up to me when I was on my community rotation at a Publix in school, and someone said, "Here to fill my Huctaz." I said, "What are you talking about, Huctaz?" And I was trying to figure it out for like 20 minutes. The guy was like, "No, my Huctaz, my water pill." Oh, the water pill. Yes, HCTZ. That makes more sense. And give me my CLA with it. You know what CLA was? KCl. Okay. Potassium chloride, right? Again, we're going to see why they need potassium chloride along with their thiazide diuretic, just like you were trying to allude to, right? You got to replace that potassium. The guy needed his CLA. That's what he called it. Anyway, so looking at our thiazide diuretics, these are going to be including chlorothiazide, HCTZ, chlorthalidone, and then metolazone. Those are the main ones you're going to see being used here. So what they're going to be doing is inhibiting salt reabsorption in the distal convoluted tubule, right? So we saw a drug that works in the loop. Now we have one that works in the distal convoluted tubule here. This is the major action you're going to see with this. So basically, by blocking the reuptake of sodium and chloride here, you're going to cause more of it to be out in the renal tubule. You're going to be losing more of that. Now, one major difference you're going to note with the thiazides with the loop diuretics is actually you can increase calcium reabsorption here. Okay. The reason for that is, and I'm not going to get super in depth on this necessarily, but basically you're increasing activity of this transporter here. When you have less sodium inside the cell, it wants to kind of pull it in, and so you're actually going to be reabsorbing more calcium. This will be important for a specific indication I'm going to talk about a little bit later. Specifically, it's going to be with kidney stones. So just kind of keep that in the back of your mind that with this one, you can actually increase calcium levels. Almost all the other diuretics are going to lose calcium. Okay. Anyway, so as I mentioned, these are not nearly as potent getting rid of fluid as you're going to see with the loop diuretics, but they're still okay. You can still get some good effect from this. But we typically find these are actually a lot better from a hypertensive standpoint for a long period of time. So these are actually going to be good as an antihypertensive. You may see these being used as a first-line agent for many patients. You ever see someone who's just on hydrochlorothiazide or just on chlorthalidone, something like that, that can be seen very commonly. Right? So this is a good antihypertensive class of drugs here. But you're still going to lose potassium, still going to lose magnesium, but you will see reabsorption of calcium occurring with these drugs. Okay. So again, very similar actions, right? Because again, you're losing fluid in the kidneys, so the kidneys have the same compensatory response. You're still going to see the same uric acid levels increasing. Still going to see the same hyperglycemia. None of that is different, even though where the drug is working specifically is a little different. And where do we use it? We use it for hypertension, right? This is the number one place we're going to see this being used. We use it for renal failure potentially, cirrhosis, congestive heart failure. And then kind of the unique indication here is going to be for hypercalcemia or with renal calcium stones. And you think, well, that doesn't make sense. You just said it causes increase in calcium levels. Why would I want to do that? Well, if you think about it, kidney stones are basically calcium oxalate crystals, typically, precipitating in the renal tubule. So if I get rid of that calcium out of the renal tubule, less of it's there, less of it can precipitate. So this hopefully can prevent someone from developing a kidney stone by kind of causing that increased reabsorption. Now, obviously, the best thing you could do is get rid of the calcium in the first place, but this can kind of be somewhat helpful with that. And again, here in Florida, I guess we have a lot of in our tap water. A lot of calcium, right? So people typically who don't live here normally, they come moving down here, they can develop kidney stones if they can't really handle all that extra calcium you see with that. So especially if you get like well water or something like that. Anyone ever had to grow up with well water? I probably have a lot of arsenic and other kind of nasty metals in my body right now, but due to that. But again, it's one of those things where, and again, it just tastes different, right?
Yeah, it tastes good.
Whenever I go home, yeah, it tastes. It's that mineral taste, right? It's all that calcium and probably mercury and lead you're getting in there, right? And it has a kind of a nice taste to it. Anyway.
So why do we use this for liver cirrhosis?
Due to the fluid issues, right? So again, if they develop ascites, this can be useful to help get some of that fluid off. Again, not as potent as a loop, but it could be a potential use for it. So anyway, so typically who this will work better in from a from a hypertensive standpoint, typically works better in African American patients, obese patients, elderly patients, or if they're in a what we call a salt retentive state. Okay. Basically what you're seeing is that in the short term, yeah, you get rid of some of that blood volume, right? But we mentioned there's a lot of compensatory mechanisms that kind of blunt that effect. So overall, you're going to find that the blood volume doesn't really change significantly when you're on this for, say, for years, right? I'm not talking about just in a few days, but let's say a few months to years. However, chronically what we end up seeing is that you see this kind of this vasorelaxant sort of effect. Kind of ancillary effect that happens is so chronically you see that total peripheral resistance is going to go down because the vessels are dilating a little bit, and also you're going to see decreased waterlogging, or basically over time if you're in this really salt retentive state, you hold on to a lot of sodium, that sodium's got to go somewhere, and so some of it will go into the endothelial walls. And again, where does salt go? Where it follows Water. So those vessels get thicker because they're full of salt and water. And if you can get rid of some of that, get rid of some of that salt out of those vessels, guess what? They're going to get a little thinner, and they're going to have that pressure go down, right? It's kind of like increasing the diameter of your hose, so to speak. The pressure is going to go down in those cases there. So less wall thickness, bigger diameter, and so you're also going to find as well, get some of this kind of decreased vascular responsiveness to things like norepi. So overall, very good as an antihypertensive agent. You can use it as a first line by itself. Oftentimes people will be on this plus something else very often. Very few patients can be managed effectively with just one antihypertensive drug, but this can be a good backbone in one of those regimens here. So very frequently we see someone who's on this and HCTZ, or this and chlorthalidone, or whatever the case may be. Okay. So again, the adverse effects are all going to be very similar here. Only other thing that's different would be the hypercalcemia you can develop with this. That would be the only difference with that. But again, all the side effects are going to be very similar as the loop diuretics. Probably not as severe, just due to the fact that they're not going to be as potent at getting rid of that volume, getting rid of those electrolytes as a loop diuretic would be. Okay. Again, same things we're going to see with this. Some patients may get a little photosensitive, so again, it's going to be dependent on the patient. Sometimes they may need to wear more sunblock when they're getting out in the sun, things like that. But again, overall, very well tolerated. Just be aware anytime you're messing with blood flow or vessel dilation or anything like that, a lot of the antihypertensive sexual dysfunction can be a side effect from this. So impotence can be a big problem for a lot of male patients who are getting these medications, and this is going to be one of those cases there, right? So just be aware, warn your patients about that. Again, if they already have pre-existing erectile dysfunction, this is going to be worsened by that. So you may need to have some additional aids with that. So, if we have certain medications for that, etc., which we'll talk about later in the urology section. Anyway, constipation can also be a side effect with this as well. Calcium tends to cause constipation, so that kind of makes sense. The big thing to note here is that thiazides, ineffective at very low creatinine clearances. So loops retained efficacy even at below 30 mLs per minute. Thiazides tend to not work so much anymore, with one notable exception. This is going to be metolazone. Metolazone or Zeroxylin still retains efficacy even at creatinine clearances less than 30. This is a really good drug if you have someone who has, like, say, chronic renal failure. If you needed to give this, let's say they're on a loop diuretic, but they needed just an additional push, metolazone is a really good drug to add on to that. At one time I had a nephrologist tell me, he's like, oh yeah, metolazone is great. You can make a rock pee. I was like, okay, that's a really good way to think about it, right? So it's very good to add on to something else because, again, it can work kind of synergistically. So I see a lot of patients who come in to our infusion center with chronic kidney disease, and we'll give them, like, say, Lasix plus metolazone, and again, it'll give them a little bit of synergistic effect there, and they can really get rid of a lot of extra fluid they need to, right? So it can be a very good option. Okay. As I mentioned, again, NSAIDs, same interaction here. You're going to find the prostaglandin effects can kind of blunt the antihypertensive effects you're going to see with that. And then again, be careful with things like, messing with the potassium levels. That can interact with a lot of other things like antiarrhythmics, as we'll talk about later on in this section. Okay. As I mentioned, very good for low-dose thiazides, very good as a preferred agent for hypertension because they're very well tolerated for the most part. Okay. Getting into our potassium-sparing diuretics, what do you think these do? They spare potassium. Yeah, okay. So we've already seen two classes of drugs that get rid of potassium. Now we're going to look at a few that are going to be sparing that and going to try to hold on to more potassium here. Basically what you're going to find, and again, this is the collecting duct here, right? So again, we've kind of moved from the loop to the distal convoluted tubule. Now we're getting into the collecting duct, right? And so this is where we're going to see things like aldosterone is going to be activated here, right? Activating these transporters here. They're going to cause increased uptake of sodium, but increased excretion of potassium. But one of the things we're going to find that we'll have kind of two delineations here. One are going to be aldosterone antagonists, which will help to increase potassium levels, but we're also going to have the actual true potassium-sparing diuretics. We're actually going to block reuptake of this sodium transporter right here. So again, their actions blocking luminal sodium channels here. By inhibiting those transporters, you're going to cause potassium to be spared essentially, to where you're going to block reabsorption of sodium, but you're going to hold on to more potassium. So, okay, so if I had asked you on a test question, which one of these is going to cause hyperkalemia? Or if I say you have a patient with a potassium level of 6, which drug would you not want to give this patient? Right, you got to make that inference. Be okay, well, I see they're already hyperkalemic. I see the reference range it gave me, so I know that's high. What drug can exacerbate that? You'd be looking at one of these potassium-sparing diuretics as being one of the causes, or it could be something not great for that patient. So just be aware of that. Again, these are pretty wimpy from a diuretic standpoint, but what's kind of the nice thing about this, I could maybe add on to something else. It's a benefit. Oh, we'll talk about that in a little bit later. But again, if I'm giving them loop diuretics, it's causing them to be hypokalemic. and I add something like this on, it can balance it out, right? So very frequently you'll see something like a thiazide plus one of these potassium-sparing diuretics, or a loop plus one of these potassium-sparing diuretics, try to balance out that potassium level and keep it in a normal range there. Okay, that's a very common combination you'll see with that. So the two primary ones we'll see for potassium-sparing diuretics is amiloride, and then we also have triamterene. These don't get used too frequently by themselves, generally added on to something like HCTZ or chlorthalidone or something else like that, again, for chronic management of hypertension. Again, same indications as the other diuretics, however, they're going to be very wimpy, typically not used by themselves to get rid of fluid if that's what you really need to do. Very similar adverse effects here. The main difference is you're going to see hyperkalemia. So again, this can be worsened if you add it on to other drugs that can increase potassium levels. So we're going to see that's a big deal with the ACE inhibitors. That's going to be a big deal if they're taking potassium supplements, right? And again, when patients are taking salt supplements, let's say they have a CHF, they need to get a low salt diet, and they use a salt supplement. Anyone know what those salts usually are? It's usually potassium, right? So again, you have to be careful with that because they're on a salt potassium supplement that can worsen the hyperkalemia as well. Not only that, but yes, sir.
So if we give loop diuretic with potassium-sparing diuretic, do we still give potassium supplement, or we bypass?
Just depends, right? So again, you have to see how the patient's going to respond to it. You can have someone who, I have some patients who have to be on just incredible amounts of potassium because their kidneys just happen to be wasting so much of it. So say for instance, we have some patients like our cardiac unit, right? So those kids are very, very mindful of their electrolytes because so much of the cardiac physiology is affected by that. But say for instance, we have one of them on total parenteral nutrition, which is like IV nutrition, through an IV. And we're trying to maintain their potassium levels. A normal kid may need like 2 or 3 milliequivalents per kilo per day of potassium to stay normal, right? Some of these kids need 6 or 7 milliequivalents per kilo, which is a huge amount of potassium. So it just depends on kind of the balancing act. So if you have them on a loop and say triamterene, but they're still hypokalemic, just add on something else, right? Anyway, other things you can see, megaloblastic anemia is kind of a unique side effect you can see with triamterene, and then azotemia with amiloride. But other than that, pretty well tolerated, typically added on something else, not used by themselves. Now, the other side of the potassium-sparing diuretics is the aldosterone antagonists. And so typically with aldosterone, as we mentioned, it's going to cause increased reabsorption of sodium and decreased reabsorption of potassium. So you're going to be losing more potassium outside of into the renal tubule. You're holding on to more sodium here. Okay. And again, when does aldosterone get expressed? Like, what's kind of the main thing that drives aldosterone levels up? The renin-angiotensin-aldosterone system, right? So again, when angiotensin 2 is in increased levels, aldosterone is going to get expressed here as well. Okay. And again, we'll kind of look at the whole cycle in just a little bit later, but that's the main thing you're seeing with that. So again, if I can block the effects here of aldosterone by giving a drug, that can help to block that reuptake of sodium. I can hold on to more potassium and lose that sodium out in the renal tubule. Okay. So the two drugs that fit in this category are going to be spironolactone and then eplerenone. Okay, aldactone and Inspira, respectively here. So, and again, they're basically binding to that steroid receptor site where aldosterone would normally bind to, and basically preventing it from interacting with that receptor there, right? Very effective when you have a high aldosterone sort of level. So if you had someone either with like a primary hyperaldosteronemia, if you had someone who had a highly active renin-angiotensin system, this is a really good drug for those patients there. And again, pretty wimpy as far as diuretics go. However, there are going to be some good effects when you're adding it with other medications. Okay, but again, what do you think is going to happen to potassium levels here? They're going to increase whenever I'm adding on one of these drugs here because they're blocking the effects of aldosterone. Okay. So clinically, where do we use this? We can add these on for hypertension. We'll actually see when we talk about CHF, this is actually recommended for patients with class 4 CHF. There's actually some mortality benefits from adding on these drugs here. So we're going to talk about that later on. And then for some edematous conditions, this can be added on with other medications. Again, not great by itself to get rid of a lot of fluid, but adding onto loops, adding onto thiazides can be very good to help get rid of that fluid there. So adverse effects. This is kind of a unique set of adverse effects with aldosterone antagonists, one of which is going to be hyperkalemia. That makes sense. We already talked about why that would occur there. The other thing to note, though, is that especially spironolactone has weak androgenic effects, which means a partial agonist at the androgenic receptors. Androgenic receptors just means what? Testosterone, right? Testosterone, DHT, dihydrotestosterone. Those are the two big androgenic hormones that we will produce, right? So that means if I have a partial agonist of this receptor, what would happen to male patients? Gynecomastia is a big one, right? You see feminizing effects in male patients who have high testosterone levels to begin with. If you only partially agonize those receptors, as opposed to having the full agonist of like testosterone or DHT, you're going to see more of this feminizing effect, which is manifested primarily as gynecomastia. Right? This is the big thing you hear about spironolactones causing gynecomastia in men. Okay. However, what could that mean in females if I have a partial agonist? See masculinizing effects in female patients, right? So that's where you can see the facial hair, you can see worsening of the acne, things like that. So again, it's one of those things where it's like, okay, well, it causes feminizing effects in men, but it can cause more androgenic effects or more masculinizing effects in females. Because again, typically they have lower testosterone activity, right? So you're kind of increasing it above what the baseline is, whereas with guys, you're going to be decreasing it below what the baseline is. Okay, does that make sense?
Is that because the enzyme aromatase or something like that?
Not due to aromatase. This is due to the fact that just the drug itself is going to be interacting with those receptors, right? So it's just going to be causing a partial agonism there.
So essentially, because that drug binds to the receptors and it's not allowing like testosterone to bind to those receptors. Okay.
Exactly. Yeah. So you're
creating less of an effect than testosterone.
Yeah, so again, it's only a partial agonist. You only get kind of like it's almost like the Diet Coke versus Coke, right? You only get the partial effects. You would, I guess, I mean, it's not the best analogy, but you kind of get the idea, right? So again, it's kind of only getting marginal effects under the baseline of what a normal male patient would be producing with testosterone alone, right? So again, you can see things like menstrual irregularities in females. You can see gynecomastia and testicular atrophy in men. So due to that, that's why you can see some intolerability with this. Typically, eplerenone or Inspra has less androgenic effects. So if patients are developing intolerable side effects to spironolactone, which is a lot cheaper, it's an older drug, you can switch them over to eplerenone, and that's going to be a better option for them. Okay, so kind of think about that as being kind of the backup agent there. Again, that's also why you oftentimes with a lot of like different birth control pills, the progesterone can interact with things like androgenic receptors and mineralocorticoid receptors like aldosterone. That's why I can see some of them will cause weight gain, some are going to cause hirsutism. We'll talk a lot about that in the women's health section later on. But just know that that's going to be a big thing we'll talk about is the progestins and their side effect profiles, right? So it's very, very important in finding just the right kind of birth control for your patients is based oftentimes on the progestin. Anyway, so any questions at this point? We have a lot more to go through this, but just keep in mind we're going to try to get caught up as best as we can. We will not have class next week. We will have class the following week on Thursday in the afternoon and then Friday morning. So lucky you. You got 4 hours of me in quick succession. It'll be great. Nothing else. I will let you guys go. If you have questions for me after class, please feel free to come up and we can talk all you want. Thank you.